The lecture is about pemphigus, and in pemphigus we have to before we start pemphigus, I would like to introduce a few terms about the different types of lesions that we could see in pemphigus. So lesions would be a bullae, or let me first say a vesicle and then a bullae. So what are these? Vesicles are, so they have clear fluid, they do not have pus, and the fluid is present in these erupted lesions. So let's say there's fluid out here, and if it's less than 1 centimeter, then obviously it's called a vesicle. So this is a vesicle, and if it's more than 1 centimeter and it has fluid inside, clear fluid, so it's called bullae. Now in pemphigus we could see vesicles that could progress to bullae. Also, in pemphigus, we can also see another type of very important lesion, skin lesion, which are called as secondary skin lesions. And that is basically erosions. All right. One is erosions and the other is crust. So when you see erosions, let's say one of these bullae, they rupture. So the skin is exposed, and that is why you could see the skin, the lower parts of the epidermis, and that is why we call it as erosions. And when these erosions they dry up, or obviously these erosions on the surface, they would be having serum, they would be having, in this case obviously, clear fluid. So when they dry up they form crust. So this is how the lesions are seen in pemphigus. And what is the pathogenesis of it? Actually, the pathogenesis, let's talk about the pathogenesis of pemphigus. So let's say this is your stratum corneum, and obviously below that you have a thin layer, stratum granulosum, and then you have stratum spinosum, and then you have stratum basale. All right, now stratum basale has the epidermodermoid junction, but the pathology actually lies in the part called as stratum spinosum. Now, what is the problem out here? Let's say these are the cells, these are the keratinocytes that are polygonal. Now, this normally these keratinocytes, okay, they have these junctions. All right, these junctions that are in blue. So these junctions that are in blue are called keratinocytes are actually called, let me just write keratinocytes, and the junctions are nothing but they are desmosomes, correct? So what happens is that out here in desmosomes, because we are studying the Pemphigus vulgaris group, there is antibodies that are mediated against these desmosomes, and therefore Pemphigus vulgaris is actually an immunobullous disorder because it involves the immune system. That is why the antibodies. Bullous because bulla are seen, and it's a disorder obviously. So this is an immunobullous disorder. And about what happens later, all right, so we saw about the keratinocytes, right, about these antibodies being targeted against. These antibodies, they come, they're gonna bind. These antibodies bind here, they bind here, they bind here, and they cause destruction. Eventually there's destruction of the desmosomes. So what happens later is that, let's say, the original cells, the keratinocytes that were there, all right, the keratinocytes with the normal, in the ideal situation as a happy family, the antibodies come and they break this happy family down, and what they do is that they make it a sore, very sad three individuals, and these individuals are now called as Zang cells. They are called as Zang cells. And what's so special about the Zang cells is that they have a very large nuclei. They have a large nuclei with perinuclear halo. So they have large nuclei, enlarged nuclei with perinuclear plus perinuclear halo. About that being about it. Now, once we've spoken about the pathology of this particular disease, we are going to focus much upon the Pemphigus vulgaris group. Now, Pemphigus vulgaris, it occurs obviously because of IgG antibodies, all right, against the desmosomes. And in particular, the desmosomes also is a protein, so it has a particular protein called as desmoglein, and desmoglein 3. Also very important high yield point is that, no, let me just write it, no, desmoglein 1 could also be affected, but it's desmoglein 3 greater than 1. If desmoglein 1 is greatly affected, then the disorder is going to be pemphigus. It's going to be pemphigus foliaceus. All right, so it's going to be pemphigus foliaceus. Now we are studying Pemphigus vulgaris because vulgaris basically means common. So the most common type of Pemphigus is going to be Pemphigus vulgaris. So it's better to focus all our attention on Pemphigus vulgaris. As I said, the target protein is going to be desmoglein 3. Now, talking about Pemphigus vulgaris further, we've spoken about its pathogenesis. We've spoken about why it occurs. Now let's just talk about what your patient is going to look like. Your patient is going to come as a 40-year-old patient, 40 to 60-year-old patient whose complaints are going to be burning sensation. Why? Let's talk about that. The burning sensations obviously because of the erosion that has occurred. Now, because when the skin is eroded, the lower epidermis is going to be noticed, right? So because the lower epidermis is exposed, rather, let me write exposed, there is going to be a lot of burning, which is followed by certain amount of erosion, because of the erosion. And this is going to be the complaint of the patient. Obviously, cosmetic complaints are going to be seen, which is very common, which does not need any mentioning. But what's important is that what features are we going to see? Well, the features, let me write about the features on examination. All right, so on examination, you're going to see something called as a flaccid bullae. Two very important things that you're going to see, as in the very basic introduction I spoke about, that you're going to see a bullae. Obviously, a vesicle would be the early form of the disease, and you are going to see one of the secondary skin lesions. So you're going to see a secondary skin lesion, and you're going to see the primary skin lesion. So you see a bullae and you see erosions. So that's the entire point of going to the basics. Obviously, erosion, and this is why the entire subject becomes so easy. So it shows flaccid bullae, which is erosion. And as I told you about the entire pathogenesis, this is the bullae, and when it ruptures, the skin is exposed, obviously, because this was the upper epidermis, and this was the lower epidermodermal junction. So now the skin is exposed, and therefore this is called as an erosion. And this erosion, when exposed, causes obviously burning, because of obvious reasons that does not need a lot of explanation. So that is the features. Now, clinical signs that are very important for the diagnosis of Pemphigus vulgaris is 1 and 2. One is Nikolsky sign, Nikolsky sign, and the second one is Bulla spread sign. What actually happens? Let's say if this is your bullae, all right, and the physician applies pressure out here. We are going to talk about Nikolsky's. Okay, Nikolsky. All right, so let's say if the pressure is applied tangentially, so what happens is that this is the fluid inside. What happens later is that because of the application of pressure over the bullae, the lower layers are going to separate. Obviously, they are separated, but they separate even further, and you could see that the lower areas of the upper epidermis is separated from the lower epidermis. And this can also occur in an erosion, because in an erosion, the layers are yet, when we see in the histo slides, obviously the layers are split apart. So the lower epidermis, on application of the tangential pressure, is going to separate from the upper epidermis. and this is nothing but Nikolsky's sign. Now, the other one that we need to talk about is the Buller spread sign. What actually happens is that, let's say this is your Buller, and when you apply pressure again over the top, let's say not tangentially, directly over the top or in this manner. So when you apply pressure, the Buller is going to spread, and this is called as a Buller spread sign. Why does that occur? Because the Buller is flaccid Buller. Now, the other very important sign, or on examination, what else you could see on examination, I missed out one very important thing which I should have mentioned, is that you can also see oral skin lesions, and that is a diagnostic factor, because 90 to 95% have an oral skin lesions when it comes to pemphigus vulgaris. How do you want to diagnose it? Let's come to the diagnosis really quick. Obviously, you have three diagnoses. One is the Sang spear, other is your histology, histo, and the third is your fluorescence. Why fluorescence? Because let me use green for that, because antibody. So you could do an antibody fluorescent testing, direct immunofluorescence. Now, Zhang smear. Why Zhang smear? Zhang is the simple, as I explained in the start of the lecture, that these are your normal keratinocytes, and when the desmosomes they break, they form these circle sad cells called as Zhang cells, and the Zhang is from the name coming from the Zhang smear. We use the Zhang smear to check it. The second way of diagnosis is going to be histo. Now, on an histo slide, what you're going to observe is that, let's say this is your stratum corneum, you have your stratum granulosum, which I'm not going to care to draw, but obviously in your stratum spinosum layer, you're going to have separation. Let's say this is your normal keratinocytes that are everywhere, and this is your normal keratinocytes that are present, and this is your stratum basal, and here you have your normal keratinocytes again. So in your stratum spinosum, you have the separation, which is why a ballet-like appearance is seen, and this is what we see as the suprabasal. We call it as the suprabasal split. Why the suprabasal? Because obviously out here it's above the basal stratum basalis, and there's a split above the stratum basalis. Also, you could call it as an intraspinal split according to me, but we do not say that. And what is very important is that there's a tombstone appearance. For that, we'll have to go into the very important pictures out here that suggest so obviously this is your stratum. Let me use black. So this is your stratum corneum, this is your very thin stratum granulosum, and this is your stratum spinosum. So as you see, the stratum spinosum is split, and this is again your stratum spinosum, and out here is your stratum basal. Now, because you see as the basal are connected to the dermoepidermal junction, and if you see closely, these basalis also do that are supposed to have a desmosome. Some of them are affected, but that is why they appear separated, and what they give an appearance is of tombstone appearance. They give a tombstone appearance, correct? So this is a very important diagnostic marker again on histology. Coming to the third way of diagnosing it. Obviously, the third way of diagnosing was fluorescence. So fluorescence, or direct immunofluorescence, if I do not, let's say, if I say direct immunofluorescence instead of the entire word, and I just write DIF, I hope that's fine. So when I say DIF, what I can see is that in the intraepidermal, we're going to see antibodies, obviously, that are detected intraepidermal, because desmosomes are intraepidermal. Desmosomes is exactly the protein against which these antibodies are produced, and desmosomes themselves are intercellular. They are not intracellular, they are intercellular. So when you see an fluorescent image, you see a fishnet appearance. Apart from that, obviously, what do you want to use for treatment? And what do you want to use for treatment before using let's just talk about treatment. Obviously, because it's an immune disorder, you want to go for steroids, which you want to taper later. What else can you use? You could use a cyclophosphomides. They are cytotoxic drugs that could be used. Side effect, bladder hematuria or uh, bladder hematuria or hemorrhagic cystitis. And another very important drug that has come up is rituximab, which is an monoclonal antibody against CD20. CD20 are present on B cells, so you are causing death of B cells, those overactive B cells that are producing all these antibodies against your particular antigen of desmoglein 3. Now before we go, I just want to show the important diagnostic features, how you could see obviously lesions in the face, very important because 90 to 95% have it. Lesions in the oral cavity, you're going to have erosions, you're going to have blisters, you're going to have bullae would be the correct terms, again the oral lesions that we can see here, and these are the erosions. Now these bullae are flaccid bullae, very important, and these erosions are having a tendency to expand, they do not heal. So let me show you the other image, and out here we can see that these erosions have a tendency to expand, and they do not heal quick. Why they do not heal quick? Because the defect itself lies as acantholysis, that is damage of the desmosome desmosome damage at stratum spinosum. So that about being it, and we are done with uh, Pemphigus vulgaris, the most important. Thank you.